ahead and get started. My name is Colleen Berry. I'm pleased to have the opportunity to chair this session today. In this session, we have 3 speakers, presenters, and 2 discussants. And I think that our goal with this session is to do things a little bit differently from the traditional setting for a research panel. That is, I think we're a little less interested in sort of presenting a narrow research study with the methods and the results and the implications and the limitations, and rather using this time together to provide more of a sort of a sweep and an overview of this field of trying to understand the Wellstone-Domenici mental health and addiction parity law, both in terms of what we're beginning and just really at the early phases of knowing from the research literature about the effects of the law, but also sort of what we know and what we're understanding about issues related to how the law is being monitored and enforced. And so we wanted to build a research panel that could touch on all of these aspects. As most of you know, the intent of the law was to eliminate differences between insurance coverage for mental health and addiction services and the rest of the medical care insurance benefit. And the ACA has significantly extended the reach of the Domenici-Wellstone law by applying it to a variety of new marketplaces. So we also wanted to touch on some of both the early research and also information related to monitoring and enforcement of the extensions of parity under the ACA. While the Wellstone-Domenici law applied only to private insurance offered by firms with 50 or more employees, the ACA extends its provisions to health insurers offering individual and small group coverage through the new exchanges referred to as the marketplace. The Wellstone-Domenici law required parity for Medicaid managed care, and the ACA has extended the requirement to Medicaid alternative benefits plans. And we know also that there's been this sort of rollout of regulatory guidance with the release of the federal parity interim final rule, the final rule just most recently in March of this year, release of the final rule related to Medicaid and CHIP. And so research is underway to try to really get a grasp on what is happening, and parity advocates and public officials have been tracking how the law is being implemented. So our 3 panelists will give us a sense of what's going on from a research standpoint, and then I think our discussants will help us think about both the issue of what's going on the regulatory side and whether we're sort of asking the right questions from the research perspective. So part of the goal here is to generate sort of new research agendas as well, and to make sure we're sort of digging into the issues that are most important to understand with regard to this law. So first, let me just say a brief word about, and I'm going to just introduce everybody at once so as to focus the majority of our time on the presentations and discussion. Hayden Hauskamp is a health economist and a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. She's an expert in mental health and substance use disorder policy and pharmaceutical policy and end-of-life care research, and like pretty much the whole panel, she's been working on this issue for maybe 15 years or more. Francisca Zokor is our second presenter. Francisca is a vice president of research and evaluation at Optum. She's been at Optum for 17 years. She's conducted research on the dissemination of practice guidelines for the treatment of depression within a managed behavioral health care setting. In particular, she's focused on workplace depression, and she's been involved with multiple NIMH studies looking at issues related to behavioral health, including the study that she's going to talk about today, which looks at the effects of the federal law in the context of using the Optum data to help us understand third presenter is Domenici-Wellstone, is a professor at the Heller School of Social Policy and Management at Brandeis. He's a health economist who's worked mostly on financing issues in mental health and addiction through the Schneider Institute for Behavioral Health at Brandeis. Following those three presentations, which we're going to limit to 10 minutes to try to, again, be able to have some time to discuss these issues, both across the panelists and the discussants, but also with all of you, I hope. We have two discussants. Kirsten Beronio has over 15 years of experience in public policy development regarding mental health and substance use disorders, including leadership positions in the Senate and in the executive branch of the federal government. She currently is the Division Director of Behavioral Health and Intellectual Disabilities at ASPE. In this capacity, Kirsten has been a great source of information for all of us in the research community who have struggled to understand the complexities of both the policy and how the policy is being implemented in the field. She is an advisor on mental health and substance use disorder policy across HHS and in connection with other agencies and with the White House with regard to behavioral health policies. And finally, Howard Goldman will be our last discussant. Howard is a professor of psychiatry and the director of Behavioral Health System Improvement, the Behavioral Health Systems Improvement Collaborative at the University of Maryland School of Medicine. He has been for many years the editor of the journal Psychiatric Services. He was the scientific editor for the Surgeon General's report on mental health, and he is a member of the National Academy of Social Insurance and the Institute of Medicine, and he led the evaluation of the Comprehensive Parity Directive in the Federal Employees Health Benefits Program. So without further ado, I think I'm going to turn it over to Hayden right now. In addition to asking our presenters to keep their comments to 10 minutes, we've asked our discussants to keep their comments to 10 minutes. So after that, we'll have the chance to talk about this issue with the entire panel. Please. Thank you.
So I am part of a very large research team that has worked together on many analyses of parity for a very long time. I want to acknowledge my most frequent collaborators on all of this, and also acknowledge the support that we're so grateful to have received from NIMH and from NIDA to do the work we've done over, as I said, quite a long period that we've been thinking about parity. When I think about parity, and about the large body of research on parity, I think of sort of four phases of research. Phase one focused on the effects of state parity laws and other pre-MPEA, meaning Mental Health Parity and Addiction Equity Act, policy changes on average use and spending. And first, a number of studies assessed the effect of state laws, which varied in their comprehensiveness and were limited in their reach by ERISA. The studies generally found little effect on behavioral health service use associated with the state laws. And then these studies were followed by the evaluation Colleen just mentioned, led by Howard Goldman, of the Federal Employees Health Benefits Program parity policy that was implemented in 1999. The FEHB policy required comprehensive parity, but encouraged plans to use managed care techniques to manage the expanded benefits. And the evaluation of that policy found that parity implemented in the context of managed care had little impact on average total behavioral health spending or utilization, but did result in lower out-of-pocket spending for users of these services. The next round of research looked not just at the average effect across all enrollees, but looked at differences across the distribution of behavioral health spenders and across different types of illnesses to try to understand whether parity had a differential effect on folks with the highest spending or individuals with the most severe conditions. These studies did find evidence that parity policies disproportionately improve financial protection for these individuals who were the primary targets of the policy. And I think the findings from phase 1 and 2 really helped advocates to overcome what had been a long-standing opposition to a comprehensive federal law by showing the limited effect that occurred on total spending and the benefits that could result in terms of improved financial protection for users of these services, and helped pave the way for the federal law. The law was passed in October of 2008, obviously, with implementation a year later, and the interim final regulations took effect for plan years on or after July 2010. Phase 3 has involved the study of the early effects of MHPA on coverage for employer-sponsored plans affected by the law and on utilization and spending patterns. Given data lags that are always going to affect what we do in terms of evaluating the impacts of policy changes, Phase 3 has been comprised of studies that use data for the early years of implementation before the final regulations were implemented for plan years that began just over a year ago. And so finally, Phase 4, where we're all in this room interested in heading now, this phase will be able to use data once everything was final, once the final regulations were implemented, and also after the Medicaid and CHIP regulations went into effect recently. I want to highlight a few of the studies from Phase 3 to give a flavor of the kinds of work that's been going on over the past couple of years looking at MHPA's early impacts. And I'm going to intentionally focus on work that our team has done and avoid talking about what my fellow panelists have been working on, because they're going to tell you about what they've been doing. There are two main studies that looked at whether plans were, in fact, complying with MHPA requirements initially. And that included a 2013 study conducted by NORC and sponsored by ASPE that analyzed several benefits databases to assess compliance with the law, and then also the commercial plan survey that was fielded by Brandeis back in 2010. And these two studies found that plans had, in fact, made substantial changes to their benefits in response to the law overall, and only a very small proportion of employers dropped behavioral health coverage entirely rather than implement parity. But they also documented that a sizable minority of plans or health plans were still offering benefits inconsistent with parity in those early days post-implementation. And Hopkins is going to tell you about some of the results from their newer data in a few moments. Susan Bush led a study of the year one effects of MHPA using data just through 2010, so it was an early study, on SUD service use using Aetna data and comparing enrollees who were subject to parity for the first time under the law with enrollees that had previously been subject to a state parity law. And she found no effects on the probability of SUD use and only a small increase in SUD spending per enrollee. But again, she had to study a period during which the interim regs had not been implemented, or most folks weren't affected by those regs yet. More recently, using multiple years of data through 2012, Beth McGinty led a paper that looked at MHPA's impact on out-of-network SUD service use. Unlike many previous parity policies, MHPA requires parity in both in- and out-of-network benefits, so it's important to see what's happening on the out-of-network side. And she found that MHPA was associated with an increase in the probability of using SUD out-of-network services, a higher average number of SUD out-of-network outpatient visits, and increased average total spending on those services among users. Kelsey Berry led an analysis that looked at 2 state exchange websites to see how insurers in those states were presenting their behavioral health benefits for their exchange plans to potential enrollees, and to try to figure out whether their presentations of their coverage were consistent with parity requirements. And she identified several types of apparent discrepancies with the requirements, and I'll show you a couple of examples from her paper here. These apparent discrepancies could affect consumers' plan enrollment decisions, since benefit design information that suggested unequal coverage or limitations specific to these kinds of services might lead enrollees to choose a different option, and that could lead to adverse selection on the exchanges. A couple more Phase 3 studies. Kelsey Berry also recently completed an analysis of legal challenges to MHPA and state parity laws, and one of her findings is that many of the lawsuits that have been filed have focused on care for autism or eating disorders, which are conditions that the Brandeis Health Plan Survey has documented were excluded by a sizable minority of health plans post-MHPA. And that preliminary finding led us to focus on parity's effect specifically on treatment for these 2 conditions. So Liz Stewart led an analysis of changes in service use among children with autism spectrum disorders associated with parity implementation using market scan data and an interrupted time series design. And she found that MHPA implementation was associated with an increase in the probability of children with ASD receiving mental health services and functional therapies like speech and language therapy, occupational therapy, and physical therapy. And also, among users of those services, increases And she detected increases in total spending for these services that were attributable to the law, but no increase in out-of-pocket spending, suggesting that the law provided improved financial protection for families with ASD, for the families of children with ASD. And then finally, an analysis of mental health and substance use disorder use among individuals diagnosed with eating disorders using a similar design, we found that MAPIA implementation was associated with an increase in the number of outpatient mental health visits among users, corresponding to about 2 visits on average in the first year per year, but also no changes in out-of-pocket mental health spending for these individuals. So again, it appears that there's improved financial protection there as well. So as I noted, my fellow panelists are going to discuss some of the other phase 3 work that they've been working on. And I just want to sort of talk for a second about where we're headed now with phase 4. We'll soon have data available for the period after the final MAPIA regulations went into effect. And then within a relatively short period of time, we'll have some data post-Medicaid and CHIP regulations. And as we move into phase 4, it's important to continue to assess the effects on employer-sponsored group plans now that the final rules are in place, but also to look at Medicaid managed care plans, the alternative benefit plans, CHIP plans, and plans that serve the individual small group markets on the exchanges. That'll mean monitoring coverage of these plans to make sure that the benefits they're offering are complying with the rules, and examining effects on out-of-pocket spending. The primary goal of parity has always been to improve financial protection, especially for the sickest individuals with the highest spending. And many had hoped that parity would also increase utilization and improve quality, but that was never the primary goal and shouldn't be the bar against which we measure its success. But by equalizing coverage, parity did level the playing field in a sense in terms of the financial protection that's offered and the incentives for using particular types of treatment. So pre-parity, coverage was generally more generous and more equitable for psychiatric medications and primary care treatment relative to psychosocial behavioral health treatments and specialty behavioral health care in general. And so we'll want to see how parity affects where people get care and what specifically they get. So not just look at what happened to the probability of inpatient use and what happened to the probability of outpatient use, but look at particular types of services and the settings where they're delivered. As for phase 2, we'll want to look not just at average effects, but look at effects for the highest spenders and those with severe illnesses. I think phase 4 research is definitely going to need to grapple with the challenges of studying the black box of non-quantitative treatment limitations, the NQTLs, things like the application of medical necessity criteria, provider network management, and fees, and utilization review strategies. Just as it's hard for regulators to observe and monitor NQTLs, it's going to be hard for all of us to study them with the data that we generally have available, and we'll have to think, I think, creatively and carefully about how to try to understand this critical piece of the parity picture. And finally, I think we can't lose track of what's happening to individuals for whom parity requirements didn't apply, and those are individuals enrolled in the Medicaid fee-for-service program, most of whom are eligible because of a disability, and for many of them, it's a behavioral health condition that disability represents. And so we also need to continue to follow what's happening with that group. So I'll turn it over to Francisca.
Give an overview of the findings that we have so far, and within 10 minutes, try to describe 4 studies that we've done in collaboration with UCLA. First of all, I want to acknowledge NIDA for providing support for our study, and of course all of my collaborators, and in particular Susan Etner, who's the PI of the study and the brains behind the analysis, because I am not a health economist, I'm a clinician, so she is really the brains behind this. First of all, for those of you who are not familiar with Optum, we're what used to be called United Behavioral Health, UBH. We are a piece of Optum Health, which is one of the divisions of Optum, a sister company to United Healthcare, which probably you're more familiar with. And actually in this presentation, I'm not going to talk about the methods or provide any data. There is, I'm just going to give you sort of an overview of what we've found so far. I do include sort of slides with, I should say Susan, as a methodologist, includes some slides and tables with data towards the end, particularly just sample sizes of the different studies that we've done. So this, of course, is secondary data analysis. We used administrative databases to look at the association of MPEA and the interim final rule on specialty behavioral health care, benefit design, utilization, and cost among Optum carve-in and carve-out plans. Optum Behavioral, just the behavioral piece, has about 2,500 customers. It includes, our largest customer, of course, is United Healthcare. Includes employers, Medicaid, Medicare, and a number of different health plans. We cover about 33 million members. That's excluding EAP, 130,000 providers, and we manage about 2,500 facilities in 50 states. So the data that we used included 2008 through 2013 data. We actually now are adding 2014 data. It includes both eligibility and claims data. It included a database that was descriptive data from our customers, our book of business, provider supply data, and 4 different claims processing engines, together with benefit design database and a parity compliance database. It's a huge study. I thought that because it was going to be a secondary data analysis, it was going to be somewhat simple. It's ended up just putting together the benefit data has been a tremendous amount of work, in part because benefit design, plan design data is really used primarily around managing the claims engine and being able to make it available through portals to our members and our care managers. It's not a reportable database. So it actually took us about a year and a half to be able to put the benefit data together in a way that we could report out of it. So in terms of some of the findings, and just so that you know, in order to do sort of a pre-post analysis, we considered 2008 and 9 sort of the pre-parity period, 2010 sort of a transitional year, and then 2011 through 13 we considered the post-parity period. So in terms of the financial requirements among carve-in plans, we found that among in-network only plans, professional co-pays decreased, while intermediate care co-pays increased. Among plans with in and out of network benefits, inpatient and professional co-pays decreased, while inpatient and intermediate in-network and out-of-network co-insurance increased. Among the few plans that were not at parity, pre-MPEA, we saw more dramatic changes in cost sharing. But among the carve-ins, one of the things was that we kind of knew this was coming. So virtually all the plans were already combining medical and behavioral deductibles even before MPEA. So starting 2008, we knew this was coming by 2010. So a lot of the data was already being combined, and a lot of customers were already starting to be at parity. In terms of the financial requirements for carve-outs, among all plans, the use of in-network outpatient co-pays decreased, while any in-network outpatient co-insurance increased. Among plans both within and out of network benefits, out-of-network co-insurance rates for all service types decreased. Among plans with in-network benefits only, the level of copay for inpatient and residential services decreased. Among plans that were actually using those kind of copays. But pre-parity, the carve-outs never really had combined deductibles, so this was sort of a really big piece for us because, especially big employers tend to have a lot of different medical carriers, and so really combining the data, we needed to develop a whole system and sort of develop how we did what's called mixed protocol. So, what's paid by the medical side versus what's paid by the behavioral side, and then making sure that we had deductibles that were in line and that accumulators, were corresponding, both on the medical and the behavioral side. In terms of the quantitative treatment limits, pre-parity, QTLs was common, of course, both in carve-in, carve-out plans. Most QTLs were annual visits or day limits, and 89, 90%, 77%, of different kinds of benefits were limited. In terms of the carve-out plans, 66% of regular carve-out plans, 74% of in-network only carve-out plans, and 73% of carve-in plans had limited inpatient and intermediate days. So both outpatient limits as well as inpatient limits were very common. Post-parity, of course, virtually all plans dropped limits. I think, Don will talk probably about those, but if we didn't drop them, we were out of compliance. So that was quickly one of the things that changed. In terms of the NQTLs, open authorization was routine in terms of outpatient. And open authorization, it basically was, when you call in for an authorization, you get 20 sessions, and you could choose whatever provider you wanted to use, as many providers you wanted to use within that 1 year period, as long as it was in network. So it was that's what was considered an open authorization, and there was ongoing review for inpatient and intermediate care. Post-parity, outpatient rarely requires pre-authorization. It's typically related to some kind of diagnosis or special treatment, and typically inpatient and intermediate care without pre-authorization could be reviewed later by request and paid with or without penalty, depending on whether the medical necessity criteria is met. In terms of use and costs, adults within carve-in, we saw an immediate increase. I think that this reflects with some of what has been seen in prior research. Immediate increases in per month plans and total spending, particularly in terms of assessment and individual psychotherapy visits. But we also saw an increase in individual psychotherapy visits over time. So both an impact immediately, but we've also sort of seen a trend that has continued to increase. We've seen increases in utilization and cost driven primarily by out-of-network services, particularly around substance use services. And then when we looked at sort of the predicted cost pre or without MPAEA, it was $6.90 versus $8.90 post-parity. In terms of adults, use and cost among adults in carve-outs, the associations with parity were mixed in terms of sign and significance, but they were higher in modest magnitude. In terms of cost shifting, what we saw was that there was an obvious cost shift from the member to the plan. So it seems like parity seemed to actually reduce the financial burden on the patient and transferred it over to the plan, which is exactly what we wanted. In terms of children and young adults, what we found was that for the carve-out, that the associations for use and cost were similar than that with adults. However, in the carve-in, one of the things that we're seeing is that there's been a significantly larger increase in utilization and cost among children and young adults. And again, we've seen that increase, particularly among substance use disorder and particularly around residential care. So in terms of the big picture, I think we found no evidence actually that, at least among our customers, that behavioral health coverage was dropped. That we are seeing a decrease in terms of the carve-out design post-parity. MPAEA improved insurance coverage, primarily by eliminating QTLs and relaxing the NQTLs. And I have no time. And in terms of the changes that we saw, as I said before, we're seeing particular changes around inpatient visits, but also particularly around children and young adults. So one of I think the things that we've seen, and I think is being seen in other studies, is that there has been a shift of cost, again, from the member to the patient. And maybe one of the things that I can talk about, some of this during the discussion piece in terms of what this has meant for managed care and particularly for behavioral health. So I'll leave it at that. I don't know how you get out. You know?
I'm pleased to talk today about commercial health plans' responses to federal parity. And this is work that's being done by a group of us at Brandeis, led by Connie Horgan, the PI, is in the audience here, and the other people named. And we're grateful for support for this work from NIDA through a grant to fund a health plan survey, and also a center grant to Brandeis and Harvard. So in terms of the context, where do we fit into this body of research that Hayden started out by describing? So there are some studies that are looking at how the federal parity law is affecting access and financial burden or financial protection. And many of these effects are supposed to flow through changes in health plan policies. So the law is intended to bring health plan policies into compliance. And so we think it'll be helpful to interpret the results of the kind of reduced form studies that look at effects on access and protection to understand what results we get from those studies. It will help to understand what specifically happened with health plan policies. And so some of the results Francisca just showed are also part of this red arrow, like the first stage of the effect. So I won't go over what the law specifies. We already covered that. And the law initially had broad support from the health plans and the MHSRs. There were some concerns about when the final rule came out about the NQTLs. But one of the concerns that's been ongoing is about possible unintended effects. One issue is that the law didn't require plans to offer or to cover MHSUD. It just said if you cover it, you have to cover it at parity. So there was concern that plans might drop MHSUD coverage, or in fact they might just drop certain diagnoses like autism or eating disorders. Another concern was that parity is about saying the level of coverage for mental health and substance use is less good than the coverage for medical care. We're going to require them to be equal. So the hopeful version is, require them to be equal, that's leveling up, right? The MHSUD goes up to meet the general medical coverage. But in fact, parity could just as well be achieved the other way by worsening the medical coverage until they're both leveled down. So that was another concern is, would that happen? It's not so likely that plans would design their whole general medical coverage around the parity law. So I'm not claiming that. I'm just pointing out that if general medical coverage was generally being hollowed out by higher and higher deductibles and things like that, then that makes it more difficult to use the parity law to improve mental health coverage. So in light of those kind of concerns, the questions we had for this part of the study were about how has coverage and management of care for MHSUD changed since 2010? Exclusion of diagnoses I won't cover today. How often is prior authorization required? And do these practices differ between MHSUD and general medical care? So we're using results from the Brandeis Health Plan Survey, which is every few years we survey health plans about their provision of MHSUD services. Today I'll mostly talk about the 2014 survey and occasionally about 2010. It's a telephone survey of private health plans, nationally representative. We ask plans about their top 3 commercial products in each of a set of 60 market areas, and we got a response rate of 80% this time. So some of the questions are this time around are recall questions where we ask the plan executive, compared to 2010, how have things changed now in 2014? And so this first one is asking the plan, how has your coverage of behavioral health services changed since 2010? So 2/3 of the plans we asked said that they'd expanded their coverage of the services they covered for behavioral health, and the rest said no change. So that's the left-hand bar. The right-hand bar is showing a very different picture. It's saying very few plans said they'd expanded their coverage, the services they covered for general medical care. Most plans, 2/3 of plans said no change, and then quite a few said other change, which is like a mix of add some services, subtract others. So we called it other change. We could have called it it's complicated. So then the next picture is showing some specific services that the plans covered, and showing that in 2010, which is kind of the very beginning of the implementation, some of these services were already well covered by all plans, like detoxification. The 2 services where we're seeing some movement, where they started out a bit lower, there was residential rehab, was only a bit over 80% of the plans were covering that in 2010, and that increased close to 100% in 2014. And similarly, outpatient opioid treatment went up from around 70% to close to 100%. So there have been gains in coverage for 2 specific substance use disorder services. When we asked the plans about their changes in cost sharing from 2010 to 2014, for behavioral health, about a third of the plans said they'd increased their cost sharing for behavioral health. That's pretty similar to what they said for medical care, so that might not be a parity effect necessarily. That might just be the general erosion of coverage that's been going on. On the other hand, 2/3 of the plans said that they'd reduced their cost sharing for behavioral health, and almost no plan said that for medical care. So that does kind of look like it could be related to parity. For general medical care, a very common response was no change in cost sharing. And when we asked them to compare their prior authorization requirements, again, the dominant response for both behavioral health and general medical care was no change, the purple bar. But there were a lot more plans saying they'd relaxed their utilization or their prior authorization management requirements for behavioral health, about a third of plans, compared to less than 10% of plans saying that for general medical care. We also asked specifically about in-network outpatient care, so this is about a specific service, and here we're comparing actual responses in various different waves of the survey. And so this is showing a tendency to decline, that fewer and fewer plans over time require prior authorization for outpatient in-network care. However, this change was already happening before the parity law even passed, so the big declines for behavioral health are happening already between 2003 and 2009, so it's less likely that's to do with the parity law. So in terms of summing things up a bit, so we're finding that for benefits, that most plans are reporting that they expanded coverage for behavioral health, but few plans are saying that for general medical care. What they mean by expanded, it could mean adding services, it could mean covering services better, reducing cost sharing, different things. So from that one question, it's a bit hard to say what form it took. Plans didn't respond to MAPIA by dropping coverage of substance use disorder diagnoses. I didn't show you that one. We did find some increase in exclusion of autism treatment. And plans coverage of opioid treatment programs has caught up to other settings, so that's closing a gap that was present before. And in terms of these other kinds of treatment limits, the non-quantitative treatment limitations like NQTLs, there was a decline in the use of prior and continuing authorization for outpatient MHSUD care. So that was the kind of the thing that may have preceded parity. I should point out that for inpatient care and other kind and intermediate care, there is still prior authorization in most plans, so the outpatient thing is only part of the story. Plus, these questions only saying, was there a requirement, whereas some of the interest would be in how stringent is the requirement. And that is pretty difficult to get at, whether you have surveys like us or whether you have benefits design databases like Francisca had. It's always a lot more hard to figure out what people mean by stringency of prior authorization, and that's why it's a harder thing to regulate than benefits. And then finally, the fact that plans are using prior authorization a lot for inpatient care, again, that may make it harder to regulate what they do on the mental health side, because if it's stringently regulated on the medical side, there's no basis for a parity challenge to what they do on the mental health side. A few limitations I should mention. Some of the changes I'm reporting may result from factors other than parity. There is no comparison group. For some of these questions, and I didn't show you this, we asked them, was this change partly due to parity? And a lot of the benefits expansions, they say, yes, this was due to parity. So that's something else we should add in. The data were self-reported by health plan officials, so we're dependent on them reporting accurately. And some questions required recall of a situation 4 years earlier, which is in a rapidly changing industry, could be a challenge. So on the whole, plans appear to have responded as intended to the parity law. From these data, we're not seeing signs of widespread non-compliance or unintended effects, though I do have to point out that there's been a lot of prominence to consumer complaints about plans not complying with parity, and a lot of those complaints, again, they're not about the benefits, they're about the utilization management side of things, which is harder to regulate. And as a result of that, the President set up a special commission to investigate compliance with parity and collect information. And one other thought is just these results are from a period when MHSUD spending was growing relatively slowly compared to some other historical periods. And if spending starts to accelerate again, then the plans may once again face more pressure from employers to tighten up the controls. Thank you.
Well, that was a great segue. Dominic mentioned the commission. It's actually a task force the president set up to examine parity, and I'm actually involved in helping to staff that effort. So back in March, the president issued a memorandum establishing a interagency parity task force to study mental health and substance use disorder parity. It's chaired by the head of the Domestic Policy Council, Cecilia Munoz, and it's comprised of departmental heads from across the government. So my head of my department, Secretary Burwell is a member, head of DOD, VA, Labor, Treasury, Office of Personnel Management, I run FEHBP, and then the Office of National Drug Control Policy are also members, as well as, I think I mentioned the VA. And the task force is focused on sort of three big topic areas. One is the need to increase awareness of the parity laws. I think folks mentioned earlier on the panel. There is a growing acknowledgement that in general people are not aware of these protections, consumers and providers. And also a need to improve understanding of the requirements. We have worked hard at the federal level to issue first interim final rules, then final rules for the commercial parity requirements for the commercial plans, the large group plans, employer-sponsored. Then we've also issued a number of rounds of sub-regulatory guidance. We most recently issued regulations to implement the parity law as it applies to Medicaid and CHIP. So there's been a lot of effort to clarify, but it is a complicated law in part because it's not just a set of requirements that stand on their own. You've always constantly got to be asking what's the comparison on the medical surgical side. So it makes it very complicated. And then the third big area we're focusing on is improving compliance and the monitoring processes that we have. to ensure that health plans are in compliance with the law. So we've been holding a number of listening sessions and a report to the President on our findings and recommendations is due at the end of October. In addition to these listening sessions, we also have established a website, and the website address is www.hhs.gov/parity. There's a page on that website where you can go and submit comments if you have, if you want to highlight a particular issue you think we need to pay attention to. So in the context of this task force and the listening sessions we've been holding, of course we've been hearing a lot from the advocacy groups about how plans are not really complying with the law. A lot of the focus is now on these non-quantitative treatment limits because as the folks on the panel have pointed out and we found in some of the work we have commissioned through my office, that plans have largely moved away from the quantitative treatment limits, the very explicit and overt ways that care was managed perhaps more strictly, or was managed more strictly for behavioral health conditions, to more of these non-quantitative treatment limits, which are more of the utilization management controls, the policies in place around medical necessity, how they structure their networks, how they structure their rates, reimbursement rates, those kinds of issues. The focus has really turned more to those, and of course those are much harder to track and monitor. We also have heard a lot about how there are certain requirements in the law that health plans and insurers are supposed to disclose certain information to consumers and providers upon request generally, and there's a lot of complaints that we're hearing that is not happening. And then just generally access. We hear a lot about the restrictions on inpatient care recently. So it's not surprising to me to see in the studies that the restriction on outpatient care are generally going down, but inpatient continues to be a problem. And then the other big area we hear a lot about is the need for more transparency. They want to know more about what's going on at the federal level with regard to holding plans accountable. But as I've stated, what the research shows us is that things have improved, and some of the bad things that people were worried about, the dropping of coverage or the lowering of coverage for medical surgical benefits haven't really happened, and that we have seen some increases in the level of protections to some degree, and even a decrease in use of prior authorization on the outpatient side, and some expansion in coverage, which is interesting. As Dominic pointed out, an increase in coverage of opioid treatment is encouraging. We have a study that we commissioned in ASPE, actually, that RTI is doing for us, looking at changes in the small group and individual plan markets. So as Colleen mentioned, I think the ACA went beyond MPIA, expanded MPIA to actually reach small group plans and individual plans, so plans that are being offered through the marketplaces, the qualified health plans established under the ACA. Those are now subject to parity, and so we're studying in 12 states sort of what effect that's had, mostly focused on the benefit, the descriptions of benefits, but looking really at the detailed benefit descriptions, not just the summaries. And we are finding an increase in autism treatment coverage, although that may be more related to state laws. There are a lot of states that mandate coverage for autism with limits, which creates problems for parity that we're still trying to sort out, frankly. And then increases in inpatient care in these markets. There was not great coverage in the past for inpatient treatment. whereas in the larger employer-sponsored plans, maybe you saw, more coverage. I think we're trying to think about, given the fact that everything's sort of the management of care is really moving to this black box of NQTLs, how do we better, monitor that? We're trying to think about what are some metrics that might be indicators of something maybe not quite right in a plan. So we have a little study we're looking at whether you might partner with large health systems to identify which plans really have disproportionately high denial rates, or which plans have really high appeals, or in which plans is there a lot of out-of-network claiming of benefits, which might indicate that maybe the network isn't really quite where it should be. So those are some areas, that we've been focusing on. And the legislation, actually, there's been legislation introduced recently that I think is quite thoughtful by Senator Warren, and that's my personal opinion, not the administration's. But it would require new reporting requirements by plans to both state regulators and the federal regulators, and would also require reporting on denial rates. We are actually going to be issuing some new requirements in that regard that were actually already established under the ACA around reporting on denial rates, which I hope will be helpful. And then in general, I think it's also, what we've been interested to learn is that a number of states are doing really interesting things around enforcement and compliance monitoring, new reporting requirements, really trying to move this look at how things are going upstream instead of, in the very recent past, we were very focused on disclosure of information to providers and consumers, and I still think that's important, but it's really hard for a provider or consumer to parse this out and to figure out whether there's a parity issue or not. So we really need, I think, more upstream, the state insurance departments, regulators at the federal level to be taking a closer look and requiring more, although we're limited legislatively in how much we can require, but states have really done some good work to do more in this area, and some state attorney generals even have done a lot to enhance compliance. The other so I think looking at states that have been very proactive, seeing what the impact has been there compared to maybe some states that have not done as much might be interesting. And then finally, the Medicaid rules are coming out, or have been issued, I should say, and they go into effect next fall. We are starting to work closely with states on implementation. It's even more complicated in the Medicaid space, how you implement parity. But I think that will be really interesting. I think there's lots of room for improvement there. That's a very high need population, and I hope to see a lot of increase in utilization there. So thank you.
Good afternoon. It's my turn. Before I talk about parity, I really wanted to say a few personal remarks. I wanted to indicate that this is my last time talking to the NIMH conference as the editor of Psychiatric Services. The position has term limits, and so now at the end of 13 years, I'm being asked to relinquish the reins of the journal, and I'm pleased to say that Lisa Dixon, who you may have heard from yesterday, will be taking over as the editor. So for another 13 years, with any luck, you'll have Lisa. And I just wanted to thank everyone, as I do every time I have the opportunity, thank everyone for support for the journal, for me as the editor, for tolerating the decisions that don't always go everybody's way, for contributing things to the journal, and for doing all the reviews. It's been a great pleasure to serve in that role. I also want to thank my colleagues who we've all heard from on these panels, and others who've kept me in the game for all these years. I've enjoyed a collaborative relationship with all of these folks, and working on grants supported by various parts of the federal government, sometimes the VA, and I've learned a great deal from working on this, and I've really appreciated it in my career. Now, about 2009, I gave a talk entitled "My Last Talk on Parity." And as you might imagine, this isn't the first talk on parity that I've given since 2009. It's the gift that keeps on giving. I realized that what I meant when I said that in 2009 was that now that the federal parity law that many of us had worked on for so many years had been passed, that the research that was done in the service of getting those laws passed, the motivation had now been accomplished. That is, we'd achieved our goal. But then I did have to realize that there were a great many scientific questions of interest besides those that just have basic policy implications, to say nothing of the fact that the policy impact over time of the law was an interesting topic in and of itself, and that's what we've really been seeing for the last 7 years since the passage of the parity law. You've heard some of the results of studies in that particular policy space, and it's been important to do that. It's important to know whether a law and its regulations accomplish their intended goal. We want to know for whom, under what circumstances, and so research has continued to be conducted on this particular topic, all of it really focused still on the direct policy issue. That is, have we accomplished the goal with parity in terms of improving insurance protection and some of the other intended or side consequences that were hoped for? But I want to talk about a few of the issues that are at what I think of as a scientifically and philosophically deeper level that also have policy implications, but don't really revolve around what was the cost impact, how did expenditures change, what part of costs changed, were they out-of-pocket costs and the like. Instead of reflecting on my last talk on parity, I'd like to talk just for a few minutes about my first paper on parity. Now, some of you may know that I published a paper with Richard Frank and Steve Sharfstein on parity. We published it in, I think, 1982. The paper was actually written or conceived in 1979 when I first met Richard when he was a graduate student working at the NIMH. Okay. He had more hair and mine was black. And I'm raising it because the title of that paper was Parity and Equity for Mental Health Care. And it raised an issue about equity at that time, distinguishing it from parity, because parity, after all, meant that the rules for coverage were the same. The equity issue was a deeper issue. At that time, people were concerned whether there would be redistributive effects associated with parity, which would mean that higher educated people of greater means would now have less expenditure imposed on them for psychotherapy, which people with less education and lower socioeconomic status would never use. So that an insurance parity law might, in fact, result in inequities with respect to distributive effects in terms of burden and benefit. We talked about it in this paper because it was one of the objections that was raised to having parity back in the day. There were a lot of other objections, like that mental disorders aren't real health conditions and treatment wasn't effective, so why'd you need insurance anyway, who cared? And then only much later, after we disabused policymakers of those barriers, prejudices, and stigmatizing discriminatory attitudes, did they raise the issue of cost and what would it. And so for all these years, and with this research that we've heard from, that's been the primary focus of our thinking is what's the impact on total expenditures, and did it change out-of-pocket expenditures, and somewhat secondarily, how did it affect probability of use and quantity of use. But there are some very deep and interesting scientific and deeper policy questions than just the expenditure question here. And our first paper actually looked at that particular issue. Now, subsequently, there have been other issues that are about equity and parity, but here it's equity in terms of the health benefits, not the income distributive or redistributive effects, but whether the changes that occur in the face of parity change the nature and quality of services for specific groups as a result of changes in probability and quantity of use, out-of-pocket spending, and the like. So while we've learned from our colleagues that for certain categories like eating disorders or substance use disorders, there actually have been changes in the probability of use, but we still need to answer the question, did those increases bring to people effective care? Was it the right care that was distributed? We know that in our marketplace today, it's not only quantitative limits, but managed care strategies that affect the distribution of services. And so we need to know whether they've been clinically wise decisions that have been made. Are we actually paying for the right services? And that's a much deeper and much more difficult question. But it's been around for a long time, going back to when we were all children and the health insurance experiment was conducted. And they showed that when you went from free care to having to pay out of pocket, you got a halving of care. The presumption was that as you increase cost sharing, people will forego discretionary services. But in the health insurance experiment, I believe it was Al Su who showed that care that was given up when the cost went up was just as likely to be ineffective care as effective care. So there were inequities that were associated with changes in coverage. And we still need to explore that question. Richard Frank asked that question back in our MacArthur network, and it prompted Jose Escarce and Audrey Burnham to write a paper on equity issues that was published in Health Affairs back before parity was passed. And then Richard headed up an effort that was later funded by NIMH on system cost effectiveness, where we tried to address the question, is the care that is given as demand changes over time, is it appropriate care? Is it the most effective care? And Richard introduced this concept of system cost effectiveness, or cost effectiveness at the system level. These remain as unexplored issues because we have been so focused on the more immediate question of what did it cost? Did it reduce outpatient care? And that's as it should be. But standing here 35 years into studying parity, I see more and more interesting questions on the horizon for us to address over time, and I find it very encouraging. And I really, it's been remarkable to be engaged by such talented researchers that we've heard from today, and to continue to work on these issues. Just a few more comments. Do I have any time, or 1 minute left? I'm happy to say that there is a mystery that probably has its roots in behavioral economics, to try to understand why in the original health insurance experiment the effect of increasing cost, out-of-pocket expenditure, was on probability of use. People either decided to enter psychotherapy or not enter psychotherapy all at one time. Whereas in a world of managed care, probability of use doesn't change very much. We haven't observed a lot of change in probability of use. All the effects of changes in insurance coverage are on quantity of use, the second part of the two-part equation. Well, why is that? What is the real dynamics of demand in the face of changing costs? And that's a question for behavioral economics that Tom McGuire and I puzzled about for like 25 years, and we really have never come up with a good way to study it. But I would love to see some really smart economists tackle that question about how do these decisions get made at the individual person level about how to use their insurance and what the effect is and where that effect is felt. Ultimately, the policy of ideal parity on quantitative treatment limits is to have no mental health benefit at all. Not that mental health care would not be covered, but that it would be distinguished in no particular way. There would be no violations of the policy if it was just covered. There is no cardiovascular benefit that I'm aware of. There's no dermatologic benefit. The demand properties of all these different services are all different. They are not static and identical. But if we had just one benefit for outpatient care and for inpatient care, we would realize what is required in parity. But that's only with respect to the quantitative benefit, and the non-quantitative in an era of managed care will remain to challenge us. So it's not like after 35 years I think we're finished, and I hope I still get engaged by younger, smarter people to work in this area, and I think we're very lucky to have heard from the speakers today, and I hope we'll have a chance to have some conversation about this. Colleen, are you going to manage the conversation?
So I don't want you to leave, just move over, and
Okay.
everybody else come on up, and let's, it looks like we have about 20 minutes, and so what I would like to do, I hope I didn't just mess it up for the next round of presenters, is first begin with some specific questions. You guys are, I don't need a chair. I'm just going to stand here or sit over there. Yeah, so everybody can fit in. Great. Let's begin with some questions from you guys, and also questions for each other on the panel. I think Howard ended with a pretty provocative idea that makes a hell of a lot of intuitive sense to me, that in an era of parity, we shouldn't have a separate and